Once the measurement of the left side has been completed, the latency markers are set manually. The measurement data table shows the latencies and amplitudes of the marked peaks for both the left side and the right side. Somatosensory evoked potentials, SSEP, of the tibial nerve. The instrument settings for the SSEP of the tibial nerve should be selected as follows. Amplification, 2 microvolt per division. Time base, 10 milliseconds per division. Stimulus duration, 200 microseconds. The limiting frequencies at Neurowerk EMG have been stored in the setup settings and cannot be directly changed. Obviously, the device settings should be configured to suit the particular diagnostic requirements. 4 different or active electrodes are placed in the 4-channel SSEP recording of the tibial nerve. Channel 1 corresponds to the electrode position C-set stroke, which is located 3 cm in the P-set direction, which means occipitally, starting from the C-set central point. The CB2 spinal recording place is used as a second channel, wherein the surface electrode is applied 4 to 5 cm below the inion by using adhesive conductive paste. In conclusion, the LB1 recording point corresponds to channel 3, while the LB5 point corresponds to channel 4. Locating LB1 is easiest if you form a straight and imaginary line from the lower costal arc to the spinous process. LB5 is easy to locate when, after feeding the iliac crests, an imaginary straight connecting line is drawn. Based on this line, you need to move one further spinous process down. The reference or indifferent electrode for channels 1 and 2 is set at Fset. Both channels of reference will be combined with a jumper cable. The indifferent electrode for channel 4 is adhered to the iliac crest. The entire examination takes place while lying down to provide maximal relaxation of the patient and to reduce muscle artifacts. The eyes of the patient should be closed and the mouth opened a little. Stimulation takes place above the pathway of the tibial nerve and below the medial malleolus. It should be considered that the cathode of the stimulating electrode is directed to the proximal, towards the head. The ground electrode is placed on the lower leg of each examined limb. It should be taken into account that the ground electrode is always moist and fastened tightly. The stimulation starts with low stimulus intensity and increases slowly while the stimuli are triggered cyclically. It is stimulated until a motor response can be seen on the big toe. Subsequently, the stimulus intensity is increased by a further 3 to 4 mA. Should a motor response fail to appear due to a disease, then the sensitive threshold is determined. This is the intensity at which the patient perceives the stimulation for the first time. In this case, it is necessary to stimulate the triple sensory threshold. After determining the requested stimulus intensity, the signal becomes averaged 200 times. Each measurement should take place at least twice and yield the same result to ensure the reproducibility of the curve. Once the measurement of the left side has been completed, the latency markers are set manually. The measurement data table shows the latencies and amplitudes of the marked peaks for both the left side and right side. Motor evoked potentials, MEP. The motor evoked potentials are shown here by using the example of the upper limb recording at the ulnar nerve. The measurement can take place while the patient is either sitting or lying down. Unlike the other evoked potentials or the neurography, we need to pay attention at the MEPs to contraindications. Therefore, it is not permissible to carry out an MEP examination if the patient has magnetizable objects in the head, has electric implants, has an unstable spinal column, has epilepsy, has a brain tumor, is pregnant. The device setting for the MEP should be chosen as follows. Amplification, 2 mV per division. Time base, 10 milliseconds per division. The limiting frequencies at Neurowerk EMG have been stored in the setup settings and cannot be directly changed. Obviously, the device settings should be configured to suit the particular diagnostic requirements. The recording electrodes are placed on the target muscle, as is the case with motor neurography, by using the belly tendon technique. This means that the active electrode is set over the muscle belly and the reference is attached to the tendon insertion. The ground electrode should be large and placed close to the recording electrodes. At first, the cortical stimulation is performed. With the lowest stimulation intensity, we are searching for the area above the head where the highest MEP amplitude occurs. Thereby, the encircling coil is placed in that way so that the center of the coil is located over the vertex, that is, over C-set. Here the field for the hand muscles is positioned. The motor threshold is then determined. The intensity is slowly increased here until a visible muscle twitch or a reproducible potential occurs. The 1.5 times threshold intensity is adjusted for the MEP examination. Since the potential in the MEP is highly variable in terms of latency and amplitude, 4 to 5 potentials should be recorded consecutively. Therefore, the patient should maximally stretch the muscle while recording. Subsequently, the stimulation takes place at the level of the 7th cervical vertebrae. Therefore, the patient should relax the target muscle, that is, the recording takes place here without pre-innervation of the muscle. A further 4 to 5 potentials are recorded here. Both latency and amplitude are evaluated. To calculate the central motor conduction time, the shortest cortical and the longest peripheral latency should be used. In the results table, the individual latencies and amplitudes, as well as the calculated central motor conduction time, are shown. Needle EMG. The implementation of the needle EMG is basically equal for all muscles that are accessible for this examination. Therefore, the examination on the tibialis anterior muscle is shown as an example. The techniques outlined and described herein are essentially repeated in all other muscles, and this particularly concerns the basic application of the needle electrode and the muscle activation. The instrument settings for the needle EMG examination should be selected as follows. The amplification is 50 microvolt per division in spontaneous activity, 100 microvolt per division in arbitrary innervation, 1000 microvolt per division in maximal innervation. For the time base, 10 milliseconds per division. At the beginning of the examination, the examined muscle is shown by activating the muscle. From there, the later injection site is disinfected. The moisture grounding strap is then attached to the patient and connected to the device. The examined muscle and the examined site need to be selected on the device, and the sound reproduction is then turned on. The insertion of the needle inside the muscle happens rapidly and perpendicular to the skin into the superficial muscle layers. The needle position is changed on various occasions to enable the search for spontaneous activity by fan-shaped pricking. These movements cause the so-called injection activity. This is a showering electrical activity that lasts less than 1 second. Shortly after abatement of the spontaneous activity, various spontaneous phenomena that have been triggered by the stimulus of the needle relocation can occur. Only fasciculations can be recorded with a prolonged and unchanged needle position. The next step involves potentials of single motor units being recorded by light activation of the muscle. For this step, the needle is repeatedly pricked in a fan-shaped manner into the muscle, and the needle position is held at different depths. Simultaneously, the activation of the muscle must be controlled by the examiner so that isolated muscle action potentials can be registered. If the patient enables the muscle too much or not at all, then it would be unsuitable to record and evaluate potentials of single motor units. The device can display single muscle action potentials in a triggered way and classify them by using various parameters. Therefore, a quantitative analysis of the potentials is possible. At least 3 muscle action potentials of one motor unit need to be recorded in order to accurately measure duration and amplitude. The final step of the EMG examination is the maximal innervation. This requires the patient to be prompted to activate the muscle increasingly up to the maximum. Thereby, the examiner needs to operate against the muscle and fix the joint, in this instance the knee, in order to guarantee an isometric contraction of the muscle. The study is made using several needle positions to generate an impression of the conditions in the entire muscle. In this instance, the maximum achieved density of the innervation pattern is evaluated.